yet, and the immature cell is having fate to become a complete B cells. So 70 to 80% of the cases of acute lymphoblastic leukemia is usually pre-B cell malignancy. And the marker, yes, I'm understanding that you are saying that it will be the double digit CD10 plus. So the double digit marker is positive in ALL and it's usually pre-B cell malignancy, and this CD10 positive is also called common acute lymphoblastic leukemia antigens or CALA. And also sometimes you are having CD19 and 20 as well in that pre-B cell malignancy. So acute lymphoblastic leukemia usually having pre-B cell malignancy. And the enzyme which we have talked about is the terminal deoxytransferase TDT plus, and it's basically a DNA polymerase found in nucleus, and it is found in both pre-B and pre-T cells, but it will not be found in the myeloblasts. In myeloblasts, what is present we will discuss shortly. Now, ALL is usually treated with the chemotherapy, and the cure rates are greater than 80% in some of the studies. And there's a concept of that sanctuary sites in ALL that in which there is poor penetration by the chemotherapy drugs, and from that sanctuary sites relapses can occur. So what are those sanctuary sites where chemotherapy drug can't go properly? Is, for example, testes, central nervous system, and from these two areas we can have that relapse of ALL. So to avoid that relapse or to prevent that relapse, so we use some special treatments like radiotherapy and chemotherapy, which is targeted towards those organs. And hence, if you are just giving chemotherapy or radiation therapy to such organs, so for example testes can become sterile. So this is one of the common side effect in the acute lymphoblastic leukemia treatment. So many different translocations have been reported in the B cell acute lymphoblastic leukemia, and one of it is the Philadelphia chromosomes. Philadelphia chromosome we will also discuss in chronic leukemias as well in the next podcast. So Philadelphia chromosome is basically the translocation of 9 and 22 chromosomes, and this Philadelphia chromosomes is present in 20 to 30% of ALL in adults and is associated with poor prognosis. So we have said that ALL is basically a disease of childhood, but in adults when it is occurring, so mostly the adults, 20 to 30% of adults are having this Philadelphia chromosome translocation 9 to 22, and it is having a poor prognosis. But in contrast, if we see in the children, only 2 to 3% of the children is having Philadelphia chromosome translocation. So mostly the common translocation in the children is 12-21 translocation, in which there is fusion product of two genes TEL and AML1, and it impairs the differentiation of blasts, and it is having better prognosis as compared to that Philadelphia chromosomes. So in adults, most commonly translocation is Philadelphia chromosome 922, and it is having a poor prognosis. However, in children we are having translocation 1221, and which is having better prognosis as compared to the adults or Philadelphia chromosome. Now, one of the association which needs to be mentioned is the risk of ALL increases 10 to 20% times the occurrence of Down syndrome. So 1 to 3% of patients with ALL cases have Down syndromes, and yes, as we have said, that it's usually a disease of childhood, so definitely Down syndrome can occur, is a genetic disorder of chromosome 21, and hence it can be associated with ALL because of the translocation of 12 to 21, in which we have that abnormality of trisomy 21. So right now we have talked about the most common 70 to 80% of the ALL are basically pre B cell malignancy, but we are also having that subtype of T cell acute lymphoblastic leukemia or T cell acute lymphoblastic leukemia, which is less common form of ALL, and it is most common in adolescent males, teens to 20s. So T cell basically is maturing in the thymus, so from that thymus this mass can increase, and hence it will produce as a mediastinal mass, because that thymus is the organ in which these lymphocytes are maturing. So it presents as a mass, lymphadenopathy, mediastinal mass due to the involvement of the thymus, and it's usually anterior with the presence of pleural effusions, because malignancy is associated with effusions as well. So the common sense is that when it's involving that anterior structure or the mediastinal structure, so it can compress superior vena cava and hence can form theoretically superior vena cava syndrome, or it can also cause tracheal obstruction and can produce difficulty in breathing. So again, the markers will be like peripheral smear will show the blasts, and the CD markers will be, I'm listening that you are saying that it will be the single digit from CD1 to CD9, but it will not have that CD10 or CALA, which was found in the B cell acute lymphoblastic leukemia. Now we are going to discuss about the acute myelogenous leukemia. Now myeloblasts are also immature cells like the lymphoblast, but the lineage is different, as we have discussed in the start. So the malignancy of myeloblasts, so when myeloblasts are there in the peripheral smear, we can say that it's acute myeloid leukemia, because acute and chronic differentiation is the presence of mature versus immature cells. So the malignancy of myeloblast or the immature cells of the common myeloid progenitor cells, we will call it that acute myelogenous leukemia. So it's common in adult males, and the median age at diagnosis is 65, in contrast to the ALL, in which the disease was happening in earlier age. So it's having the median age at diagnosis is 65 of acute myelogenous leukemia, and male to female ratio is 5:3, like males are much more the sufferer of this malignancy as compared to female. So the symptoms of this disease usually arises from the bone marrow suppression, as like the ALL. Like the myeloblast, when it will grow in the bone marrow, what will it do? That it will suppress the growth of the other cells, like it can hinder the growth of red blood cells and can cause anemia. It can stop the growth of platelets because they're overproducing and they are just dominating the bone marrow in a way that other cell lineages are also affecting. So for example, it can affect that megakaryocyte development, and thrombocytopenia can occur. It can hinder the growth of the granulocytes, for example neutrophils, so it can cause neutropenia. So when anemia will occur, so we will usually have the common symptoms like fatigue, weakness, pallor, thrombocytopenia when platelets are decreased. So usually classically we have bleeding disorders, and most commonly from the gums. And when there is neutropenia, so we have increased chances of infection. So the problem in one cell is causing problems in other cells because they are not dominating the bone marrow. And we can also have enlarged nodes, spleen, liver, but it's less common than ALL. So if we can see, the peripheral smear will have we will found anemia, we will have that thrombocytopenia, and we will have these myeloblasts or blasts. And the characteristics of blasts is that it is having that myeloperoxidase enzyme. MPO is positive in myeloblasts. And second most important thing in the myeloblast is the presence of the OR rods. So if we remember that what we have talked earlier about the lymphoblasts, that in lymphoblast we are having TDT positive. Now in myeloblasts we are having MPO enzyme and the presence of the OR rods. So although morphologically lymphoblasts and myeloblasts may be looking similar to a naive pathologist, but upon further pondering upon further investigation, we can easily differentiate the myeloblast and lymphoblast due to the presence of certain enzymes which are characteristics to only myeloblast, for example MPO, or TDT positive, which are characteristics of only lymphoblasts. So all rods is basically found in AML, and it's basically an accumulation of myeloperoxidase MPO, and when it can leak into the bloodstream, if it gets leaked out of the cytoplasm from the myeloblasts and eventually go into the cell, it can cause that disseminated intravascular coagulation. So acute myelogenous leukemia, or AML, can be classified into the numerous subtypes according to the WHO system based upon morphology, surface markers, or genetics. But the key subtypes which we are discussing right now is acute promyelocytic leukemia. So acute myeloid leukemia has been classified into various subtypes, but the important subtype which we are discussing right now is the acute promyelocytic leukemia, which is defined by the translocation of 15 and 17. And when there is translocation of 15 and 17, we are creating a fusion gene of PML and RARA. So promyelocytic leukemia genes is found on the chromosome 15, and retinoic acid receptor alpha is found on the chromosome 17. So when it will translocate, so what will happen, that abnormal retinoic acid receptor will form, and it will prevent the maturation of promyelocytes. So if we recall up from our biochemistry that vitamin A is necessary for the maturation of the cells. So hence, when the abnormal retinoic acid receptor in acute promyelocytic leukemia is found, the treatment is to give all trans retinoic acid, which is a form of vitamin A, and when you will give vitamin A to such patients, so their cells will eventually start maturing fully, and hence it can also cause disseminated intravascular coagulation when that or rod leaks into the bloodstream and can cause disseminated intravascular coagulation, which is severe bleeding and all along those lines, and the symptoms will present upon usage of all that coagulation factors, etc. So lastly, we will discuss a bit about the myelodysplasia or myelodysplastic syndromes. Now we have talked about acute myeloid leukemia or acute myelogenous leukemia, in which we are having presence of the myeloblasts. Now, greater than 20% of cells, upon finding on the peripheral smear, if it can contain greater than 20% of the cells, upon calculation we are seeing that there are greater than 20% myeloblasts or blasts, we will say that this disease is basically acute myeloid leukemia. But in contrast, if we are having less than 20% cells which are blasts, so we will call that disease as myelodysplastic syndrome. So it's a complete spectrum originating from myelodysplastic syndrome towards going into the full-blown acute myeloid leukemia. So again, I would like to reiterate so that you can understand this concept that myelodysplasia is an umbrella term. It's a spectrum of the disease. So spectrum starts from myelodysplastic syndrome, in which there are less than 20% blasts on examination. But when that less than 20% converts into greater than 20% of the blasts, we will say that now the disease has transformed into acute myeloid leukemia or acute myelogenous leukemia. So abnormal myeloid progenitor cells lead to ineffective hematopoiesis, just like we have said that it can cause anemia, thrombocytopenia, or neutropenia. And on bone marrow biopsy, if we are seeing less than 20% of the blasts or dysplasia, we will say that it's a myelodysplastic syndrome. But if it contains greater than 20% of the blasts, we will say that it's now acute myelogenous leukemia, and myelodysplastic syndrome can be converted into acute myeloid leukemia. So myelodysplasia or myelodysplastic syndromes are usually associated with environmental factors, for example, prior radiation, chemotherapy, usually years after exposure. So this concludes our podcast of today about acute leukemia. Thank you very much.